Hello friends, I am Dr. Madiha Zafar from Medical Education Programs, and today we are going to talk about cocaine-induced chest pain. So let's talk about cocaine first. Cocaine is a recreational drug with sympathomimetic effects in addition to being a sodium channel blocker. It can be used in a variety of ways, like you can snort it, smoke, huff, or inject it. Cocaine can induce acute coronary syndrome through vasoconstriction, atheroma rupture, or dissection. Risk of MI rises as much as 24 during the first hour after cocaine use. Cocaine-related vasoconstriction can still cause acute MI within hours or as many as 4 days later. In patients 18 to 45 years old, cocaine accounts for 25% of non-fatal MIs. Let's have a look at a scenario. 24-year-old David presented to ER with sudden chest pain while he was attending a party. First, you have to introduce yourself. Good morning, I'm Dr. XYZ, one of the physicians taking care of you today. May I confirm your name and age, please? How would you like me to address you? And how can I help you? Or you can say, what brought you in today? Can you please tell me more about it? Show some empathy as well. I can see you are in a lot of pain. Would you be able to bear with me for a few minutes? Then we'll go to history of presenting illness. We'll ask for onset, course, duration. For onset, we'll ask, when did this pain start? What were you doing when this pain started? Is it continuous since then? Is this the first time you are having such kind of pain? If had it earlier, how frequently do you get it and for how long does it last each time? Okay, now tell me about the position of the pain. Like, can you point with one finger on it? And where did it start exactly? How does it feel like? Is it squeezing? Is it tightness, crushing, dull, or sharp? Does it go anywhere? Okay, if it's going to your jaw, what about your shoulders, your back, your hands? Now let's talk about severity. So on a scale of 1 to 10, how can you rate it? Anything that makes it better or anything that makes it worse? What about walking and rest? How did you come to the clinic today or ER? Why ambulance? Did they give you aspirin or nitrates? Did it help you? Associated symptoms. In addition to your pain, did you notice any other symptoms? Now we will ask about same system symptoms. Do you have any nausea? What about vomiting? Do you have any sweating? Are you feeling tired or shortness of breath? If there is shortness of breath, then analyze it. Like what's the onset, what's the course, and what's the duration of shortness of breath? Do you feel like your heart is racing? Do you feel dizzy or lightheadedness? Any loss of consciousness? Any tiredness? Did you notice any swelling in your ankles? Then we'll go to nearby systems. We'll ask about chest, GIT, chest wall, and DVT. For chest, we'll ask for any cough or phlegm, any chest tightness or wheezes, any recent fever or flu-like symptoms, any joint or muscle ache, any trauma to your chest, any difficulty swallowing. What about heartburn or acidic taste in your mouth? Do you have any history of peptic ulcer disease? Any trauma to your chest wall or any blisters or skin rash on your chest wall skin? Now ask about DVT. Do you have any pain or swelling or redness in your legs or calves? Any history of long travel recently? Now come to past medical and surgical history. History. Do you have any history of hypertension, diabetes, hypercholesterolemia, kidney disease, coronary artery disease, or tuberculosis? Any surgeries in the past or recently? Any hospitalizations? Then ask about medications and allergies. Are you taking any medications right now? What about contraceptives if the patient is female? Any anti-TB medications? Do you have any allergies? And what about your family history? Is there anyone in your family having hypertension, diabetes, coronary artery disease, or any other heart diseases? Now, social history is very important for cocaine-induced MI or cocaine-induced chest pain. So, but asking about social history, first give confidentiality. So, do you mind asking me a few personal questions? I assure you it will be confidential between you and me. Do you smoke? How many cigarettes per day? Do you drink? If yes, then how many drinks per week? Do you use any recreational drugs? What about cocaine? Now we'll come to differential diagnosis of acute chest pain caused by cocaine. Differential diagnosis could be myocardial infarction, unstable angina, stable angina, acute pericarditis, pulmonary embolism, tension pneumothorax, it could be related to musculoskeletal, it could be gastroesophageal reflux disease, panic attack, or aortic dissection. What about investigations? So we'll investigate for ECG abnormalities, which include ST segment elevation, T wave inversion, and Q wave formation, cardiac enzymes, chest X-ray, CBC with differentials, electrolytes, PUN and creatinine, PTT-INR, lipid profile, fasting blood sugar, HbA1c, and urine analysis. So what could be the management of cocaine-induced chest pain? Any chest pain associated with cocaine use should be treated as an emergency. We'll initiate antiplatelet therapy, benzodiazepines, and nitrates. So physical examination related to chest pain could be, we'll check for vitals, BP, pulse, temperature, and respiratory rate. Then we'll start with general condition of the patient. We'll look for pallor, cyanosis, any cardiac or respiratory distress, shortness of breath, edema. On hands, we'll check for peripheral cyanosis, splinter hemorrhages, xanthoma, osseous nodes, Janeway lesion, capillary refill, clubbing, and skin temperature. Assess the radial pulse bilaterally and look for radioradial and radiofemoral delay. To examine collapsing pulse, which is an aortic regurgitation, you'll place your hand on patient's wrist and lift his arm briskly and inquire him about pain. On face, we'll check for cyanosis and dehydration. We'll also do fundoscopic examination for disc edema, cotton wool exudates, retinal hemorrhage, and AV nicking. For carotids, we'll auscultate for bruits, but using the bell of stethoscope only. For JVP, measure the JVP, normally it will decrease and no cosmal sign is present. If JVP increase, positive cosmal sign. And it could be in restrictive cardiomyopathy and constrictive pericarditis. Press on the lever for 10 seconds normally. The JVP will increase for few seconds and then decrease. An increase in the JVP greater than 3 cm is positive hepatojugular reflux and suggests right-sided heart failure. For chest inspection, inspect for chest symmetry, scars, lesion, and any obvious pulsations. For palpation, palpate the apex and locate it. Apex is palpable at the 5th intercostal, about 1 cm in size. Palpate for right ventricular heave, and would also palpate the 4 cardiac areas to check for any thrills. While doing auscultation, start at the aortic, then go to pulmonary area, then tricuspid, and then mitral for normal S1, S2, or murmurs and additional heart sounds. Flip the bell and check the apex for S3, S4. Listen to the lung basis for any crackles. Check for sacral edema and lower limb edema. This is all about physical examination of the cardiovascular system, and you will modify it according to the case. Thank you very much.